Hello everyone. The vitamins trial has created a few ripples among intensive care circles following its presentation at the Critical Care Reviews meeting in Belfast and subsequent publication in the JAMA just a couple of weeks ago. The study was set against the background of a few previous studies that used vitamin C, hydrocortisone, and thiamine alone or in combination. In one of the earlier studies, Maric et al. Used a combination of thiamine, hydrocortisone, and vitamin C in the so-called HAT cocktail in a retrospective before and after design. And they found that in this study, the use of this cocktail prevented progressive organ dysfunction, including acute kidney injury, and reduced hospital mortality among patients with severe sepsis and septic shock. Fowler et al., in a small randomized controlled feasibility study, found that intravenous vitamin C was safe and well tolerated and reduced the extent of multi-organ failure as evidenced by lower SOFA scores. And many of us are familiar with the Volum study that was published in the Critical Care Medicine Journal several years ago, in which they found that among patients presenting with septic shock, lactate clearance improved and 28-day mortality reduced compared with matched controls in patients who received thiamine. So it is against this background that Tomoko Fujii et al. Conducted this randomized controlled trial and asked the very relevant question whether the combination of hydrocortisone, vitamin C, and thiamine would increase the time alive and vasopressor free compared to hydrocortisone alone. So this study was an unblinded, randomized controlled trial conducted across 10 ICUs in Australia, New Zealand, and Brazil, and it was powered to detect a difference in vasopressor-free duration of 24 hours. The investigators screened patients admitted with a primary diagnosis of septic shock, and inclusion criteria were documented or suspected infection with an increase in SOFA score by at least 2 points, lactate levels of higher than 2 millimoles per liter, and the requirement for vasopressors for a minimum duration of 2 hours. In fact, all the 3 criteria had to be met for inclusion in the study. They excluded patients who were less than 18 years old, who had a do not resuscitate status, those who were at imminent risk of dying, patients who were diagnosed to have septic shock more than 24 hours prior to enrollment were excluded. Study drugs, if they were otherwise indicated or contraindicated, was also a reason for exclusion from the study. So they screened 786 patients, out of whom they excluded 570 patients. 216 patients were randomized, 109 to the HAT cocktail arm, and 107 to the hydrocortisone alone arm. In the intervention arm, patients received hydrocortisone 50 milligrams 6 hourly intravenously and vitamin C 1.5 grams 6 hourly intravenously and thiamine 100 milligrams 12 hourly intravenously, while in the control arm, they received hydrocortisone alone in a dose of 50 milligram 6 hourly IV. The study intervention was continued until vasopressors were stopped. Cessation of vasopressors was defined as all vasopressors being off for 4 consecutive hours with a target mean arterial pressure of 65 millimeters of mercury or a MAP target chosen by the treating clinician. The primary outcome for which the study was powered was the duration of time alive and free of vasopressors at 7 days, which is the equivalent of 168 hours after randomization. Patients had to be alive and free of vasopressors for at least 4 consecutive hours to be called vasopressor free. If the patient died during the index episode of septic shock, it was counted as 0 vasopressor hours. If a patient remained off all vasopressors for 4 consecutive hours, and then all of the remaining time until day 7 was considered vasopressor free, even if vasopressors had to be restarted after initial cessation for 4 hours, and even if the patient died within the 7-day initial period. So that was the primary outcome: number of hours alive and vasopressor free. It was 122.1 hours median in the intervention arm versus 124.6 in the control arm. This difference was not statistically significant. So the primary outcome, which was the time alive and vasopressor free, was not different between the HAT cocktail arm and the hydrocortisone alone arm. They looked at several secondary outcomes, which included mortality at different points of time. As the Kaplan-Meier curve shows here, there was no difference between arms in regard to the 28-day, 90-day ICU and hospital mortality. Also not different were the 28-day cumulative vasopressor-free days, 28-day cumulative mechanical ventilation-free days, 28-day renal replacement-free days, ICU-free days at 28 days, and also the hospital length of stay. So none of these secondary outcomes were different. The only secondary outcome that was significantly different between groups was the SOFA scores. The SOFA score decreased to a greater extent at day 3 in patients who received the HAT cocktail compared to those who received hydrocortisone alone. Thus, the main finding of this study was that the use of vitamin C, hydrocortisone, and thiamine in a cocktail form does not result in a more rapid resolution of septic shock compared to hydrocortisone alone. This study had several strengths, obviously. The strength of the study lies in its multicentric, randomized control design involving countries with vastly different healthcare settings, which adds to its external validity. Besides, it is the first large-sized randomized control trial to address this question. To minimize biases and strengthen the robustness of the trial findings, the random allocation sequence is concealed and permuted size blocks stratified by study center. Very few patients were lost to follow-up, thus minimizing the attrition bias. Now, what are the possible limitations of this study? You would argue that the primary outcome was not a patient-centered outcome. They just looked at vasopressor-free time, which may or may not be a very relevant clinical endpoint. The study was unblinded, which may have contributed to the bias, clinicians knowing what their patients were on. There was no data provided on the type or volume of fluids administered. There was no information regarding how the hemodynamic status was monitored, particularly in regard to volume responsiveness. Was cardiac output monitored at all? So these questions, or the data on these, were not available. And as I mentioned previously, they used a MAP target of 65 millimeters of mercury to titrate vasopressors. However, the clinician could use his judgment to decide on the target MAP as well. However, there was no data provided on the actual MAPs that were targeted in this study. Thiamine levels were not measured. Thiamine deficiency is in fact happens in about 20% of patients with septic shock, and it is quite possible that patients with thiamine deficiency might benefit. Others who have normal thiamine levels may not benefit, which obviously was not addressed in this study. The citrus ALI study used a much higher dose of vitamin C in a dose of 50 milligrams per kilogram 6 hourly. And this study obviously did not use such a high dose, it used a much more conventional dose. Then the most important and the most stringent criticism of this study, which was leveled by none other than Marie et al. At the Critical Care Reviews meeting, was the delay in the administration of the cocktail. The time from ICU admission to randomization was 13.7 versus 11.4 hours, a mean of around 12 hours. And there was no information about the delay from initial presentation to the emergency department and then subsequent assessment in ICU. So the actual duration of time between initial presentation of septic shock and the time of administration of the study drugs could be very, very long, and it definitely was more than 12 hours. So this raises the important question whether the study drugs were administered early enough, and would the outcome have been different if the study drugs were administered earlier, say within the first 6 hours. So that is an important limitation of this study, which clearly needs to be addressed in future studies. Apart from that, from the results of this study, we can conclude that administration of this cocktail after 12 hours does not result in earlier shock reversal, nor, based on the limited evidence available, nor does it reduce mortality. But as I mentioned, it is important to study the effect of this cocktail early enough in patient septic shock, perhaps at less than 6 hours, and see if that makes a difference to clinically important outcomes such as mortality. So that's it, folks. Until next time, goodbye.